Hey everyone, thanks for watching our group's debate on the use of restraints and seclusion on individuals with disabilities. My name is Taylor Boulay and I'm from Louisiana. I will be introducing our topic, providing a brief history, and discussing the current laws regarding the use of restraints and seclusion. Other group members include Brian Ellis from Florida, who will be arguing the pro side of the debate. Denise Byers from California will be providing the counter argument. Heather Krolicki from Maryland will be discussing the visuals presented. Kristen Markferding from New Jersey will be providing research on both sides, and Jetty Tankersley from California will be reviewing questions and answers at the end. I will begin by defining some of the terms we will be discussing throughout our debate. Restraint refers to any method used to restrict an individual's movement, physical activity, or normal access to his or her body. There are three types of physical restraints. The first is physical restraint, which is the application of force to restrict freedom of movement. The second type is mechanical, which is the use of objects to restrict movement, such as waist straps or padded gloves. The third type is chemical restraint, which involves the use of medication to control or address behaviors. Seclusion refers to the separation of someone from others, such as a timeout or going to a quiet room. There have been ethical concerns dealing with the use of physical management on individuals with disabilities for quite some time. Physical injury, psychological trauma, limitations of personal freedom, and humiliation are all risks when using physical management. In extreme cases, it has even resulted in death. However, it is arguable that restraints and seclusion are necessary when an individual's behavior poses a severe threat to themselves or to others. The use of physical management dates back centuries, starting in the 1700s with its origins in England, taking action against rebel citizens. Permission was granted under the belief that it would diminish unruly behavior and would benefit society. Mental health advocates, namely Philippe Pinel and John Connolly, fought for patients' rights of freedom beginning in the late 1700s. While individuals in England were fighting for these rights, America continued to view the use of restraint as a positive solution to problematic behavior. The English psychiatrist John Charles Bucknell visited asylums in America and referred to the reliance on restraint as an infernal barrier to the care of mentally ill patients. It wasn't until the 1960s that progress toward patients' rights were made in America. The Joint Commission, along with the Center for Medicare and Medicaid Services, established guidelines for restraint use that stated within all patients have the right to be free from restraint or seclusion of any form, imposed as a means of coercion, discipline, convenience, or retaliation by staff. Restraint or seclusion may only be imposed to ensure the immediate physical safety of the patient, a staff member, or others, and must be discontinued at the earliest possible time. Staff trainings were implemented, and the use of quiet or comfort rooms were suggested as a de escalation method. Great ethical strides have been made in considering clients' rights and will continue to be evaluated and adjusted as deemed appropriate. There are no specific federal laws concerning the use of seclusion and restraint in public schools. The Individuals with Disabilities Education Act requires a free, appropriate public education for children with disabilities, and an argument could be made that some uses of seclusion and restraint would violate this requirement. In addition, certain procedures may violate constitutional rights or state laws. Although there are some judicial cases they do not provide clear guidance on when, if ever, seclusion and restraint may be used in schools. There are three bills that were passed involving restraint and seclusion that require the Secretary of Education to declare regulations. One of the three bills, and arguably the most controversial, would allow the use of physical restraint or seclusion to be written into a student's IEP plan under certain conditions. Some groups, such as the American Association of School Administrators, argue that if the IEP cannot include such procedures, communication between schools and parents about a student's needs would be hindered. However, the prohibition on including seclusion and restraint in an IEP is seen by others as discouraging the use of such practices. In addition, the listing of seclusion and restraint in a student's IEP or behavior intervention plan may impact the reasoning in judicial decisions, making it more difficult for parents to argue that the use of seclusion or restraint techniques are inappropriate. States receive money from the Individuals with Disabilities Education Act and are told under what principles special education services are to be provided. It says that when the behavior of a child with a disability impedes the child's learning or the learning of others, the IEP team must consider the use of positive behavioral interventions and supports to address that behavior. The Department of Education has stated that while Individuals with Disabilities Act emphasizes the use of positive behavioral interventions and supports to address behavior that impedes learning, it does not completely prohibit the use of mechanical restraints or other aversive behavioral techniques for children with disabilities. The department also noted that state law may address whether restraints may be used, and if restraints are allowed, the critical analysis is whether the use of restraints or techniques can be implemented consistent with the child's IEP, and the requirement that IEP teams consider the use of positive behavioral interventions and supports when the child's behavior impedes the child's learning or that of others. As far as state laws, there was a January 2009 survey by the National Disability Rights Network that examined the laws and policies of 56 states and territories and found that 41% had no laws or policies concerning restraint or seclusion. Almost 90% allowed prone restraints, 73, and 45% required or recommended that schools notify parents or guardians of the use of these restraints or seclusion. So now that you have a brief history and summary of the laws involved, Brian will begin the discussion in support of restraints and seclusions.
Hey everybody, I wanted to start this debate by presenting some of the pros I've found on using restraints and seclusions. This particular topic is controversial and for good reason. There's been a lot of very bad instances of restraints and seclusions, and I think the line is blurred a lot as to what is ethical, moral, and legal when you have to restrain someone. After watching the videos required for this class on restraints, you can immediately draw the conclusion that restraints are not good and, topically speaking, look barbaric. I was appalled at the overuse and unnecessary use of restraint in the videos. I can only speak from my experience for the last decade working in group homes, school settings, and community settings. But I've never seen anyone use restraints as depicted in those videos. So with that being said, I feel there are a few situations that the use of physical restraints can be used. But for the purpose of this debate, I'll be discussing the use of physical restraint on individuals with autism and in clinical and school settings. So for me, the main argument is as to why we use physical restraint and seclusion is to be safe. The reason we use physical restraint in an emergency situation is to control the behavior of the student. Restraint and seclusion should only be used in an emergency. It should never be used just to calm the student down or as a first resort. A behavior analyst, as behavior analysts, we have so many ways to use intervention, and we know how to provide positive behavioral support to decrease negative behavior. However, there are situations where students have lost self-control and they will harm themselves, a caretaker, or another student. It is important to note that we should only be using restraint and seclusion unless otherwise specified by a BCBA who's been trained in restraints and seclusions as an intervention. If we are using restraint and seclusion, it should only be done if we're certified and trained, comfortable using it, and ensuring the safety of the student, caretaker, or other individual. Another reason why I think we should, why I agree that physical restraint is okay, is to prevent property damage. For example, if a student were to be in a computer lab and start to destroy computers, resulting in a lot of money, it would be appropriate to restrain him or her. I recall a situation where a teenage autism student was taking a large therapy ball and throwing it through ceiling tiles in a classroom, causing major structural damage, and had to be restrained to prevent further property damage. The next thing is behavior reduction. I also want to discuss this point. Behavior reduction, the physical restraint can be used as a behavior reduction intervention. We can modify physical restraint and seclusion into an aggression contingent intervention for students. That means there have been studies done and is immediately restrained. Data has shown that the behavior is reduced. Physical restraint can be modified into an intervention plan, but should only be implemented by someone that is competent, like a BCBA that's been trained on physical restraints and seclusions and knows how to implement them into a behavior plan. Now, ethical codes. I want to discuss them, specifically the Ethical Code 2.0 pertaining behavior analyst responsibility to clients. Ultimately, we have a responsibility to operate within the best interest of our clients, constantly thinking what is best for my client and what benefits them the most. Is restraint and seclusion the best possible option in this situation for this particular client? We have a responsibility to keep our clients safe. Our main objective is to aid in the success of our clients. Keeping our clients safe is a top priority, and if physical restraints and seclusion is not in their best interest, then we should not be using it. However, if using physical restraint and seclusion will keep them safe in that moment, we should implement it. I do think physical restraint and seclusion should be used as the last option, and I believe that there is a place for it. I've worked as an RBT for several years, and I've been trained in CPI, and I can say that I've used restraint and seclusion at times for emergency situations. I've worked predominantly with aggressive teenage to adult males, and have had to use restraint as a last intervention to prevent the individual from severely hurting himself, overpowering and harming female staff, other students, and bystanders. Now I want to talk about seclusion. It's a lot of times it's lumped in with restraints, but it can kind of stand alone by itself. Taylor defined it earlier in their introduction, but I want to just expand on the more modern viewpoints pertaining to it. So when I think of seclusion, I immediately imagine an individual in a room, locked away somewhere, and unfortunately, I know that has happened before. However, within the field of applied behavior analysis, the application of behavioral principles to modify human behavior, seclusion falls under the broader category of timeout. Timeout is operationally defined as reducing inappropriate behavior by denying the student access for a fixed period of time to the opportunity for reinforcement. When done correctly, and particularly if the stimulus being removed is in fact reinforcing, the frequency of inappropriate behavior exhibited by the student will decrease. Operationally, timeout is considered a punishment procedure due to the fact that it is used to reduce or eliminate the frequency of inappropriate behavior exhibited by the students via an environmental change. So, timeout has evolved into an educational practice with 4 distinct levels on a continuum, from least to most restrictive, starting with inclusion timeout, then going to exclusion timeout, and then going to seclusion timeout, and then finally restrained timeout. In school, seclusion seems to occur for at least 3 primary reasons. First, as a punishment procedure intended to decrease a target behavior. Second, as therapeutic practice, providing appropriate limit setting for decreased stimulation from sensory overload. And then finally, seclusion can be used in an emergency situation in which the student has lost control behaviorally and is in imminent danger of hurting someone. Seclusion can also occur for a variety of other reasons. Things like restoring order to a classroom by removing a disruptive student, and as a time to engage in reflection or problem solving, or a time to cool down. So that's pretty much all I have on seclusion. Now I want to give some evidence that I found to kind of support my claim for restraints and seclusions. So starting with safety, I did some research and found that the Department of Safety and the Council for Children with Behavioral Disorders both have given their support for restraint and seclusion under very specific guidelines. The Department of Education says the use of restraints and seclusions should only be used in emergency situations as a last resort. They also make it very clear that the only people that implement restraints and seclusions have to be highly trained professionals and who are certified. This information was from the Department of Education resource document that was published in 2012 and is available for everyone to explain how and why we use physical restraint and seclusion in the clinical and school settings. So, and next, I want to discuss how to use restraint and seclusion to reduce aggressive behaviors in behavior intervention plan. There was a study done in 2007 by Fox and Mendel, and in that study, it stated that in combination with positive behavior support, we can use aggression contingent restraints to reduce harmful behaviors. In this study, they used a token economy as their positive behavior support, and once the student became aggressive, they immediately used restraints. The study was promising, showing that it reduced the student's aggressive behaviors to 0 for a year after the use of the strategy. This was pretty profound to me. I know it wasn't on a huge scale, but the positive result was pretty interesting. And then the second study I found was done by Lingoni, is the last name, and showed that restraints could be used to fade aggressive behaviors. The study used a baseline that showed an individual was held in a restraint until he was calm for 30 seconds and then released. In the intervention phase of this study, the time he was in restraint, regardless of the calm, was systematically faded. This study also showed that his behavior was drastically reduced. This concludes evidence that I have that supports the use of restraints and seclusion in emergency situations and as a behavior reduction technique. But lastly, I just want to say, on a personal opinion, although I'm pro-restraint and seclusion, I believe it should be done on a case-by-case basis. Every individual is different, and what works for one person definitely won't work for another. I also firmly believe that if any restraint is going to take place, that the parents or caregivers should know exactly what is taking place and give their full consent. In every instance that I've personally used a restraint, there's been a witness that has observed, it was documented, and the parents or caregivers were made aware of and understood why the individual was restrained. So that's pretty much all I have. Now Heather's going to show some slides that pertain to the holds.
So on this first slide, we have 3 common restraints used. The purpose of the hold, it's important to know that the purpose of the hold is to mobilize the individual. So by mobilizing the individual, we're preventing the freedom of movement or the effective use of their arms or legs. First, we have the prone hold, and the prone hold involves laying the student on the ground and holding them by their arms and legs to prevent movement. Typically, this procedure involves 2 to 3 practitioners, as you see pictured. The second hold we have is the basket hold. This procedure can be implemented in a standing, sitting, or lying down position. This procedure involves the practitioner standing behind the student, and then the practitioner crosses and wraps the student's arms around their own torso while the practitioner holds the student's wrist to prevent movement. This procedure is implemented by 1 person. The third hold we see is the supine immobilization. This also involves lying the student on their back on the ground. In this procedure, the student's arms and legs are held down to prevent movement. This procedure is typically performed by 2 to 4 practitioners. On this slide, we have a graph. This graph represents the number of self-injurious behavior and injury in 2016 and 2017 with a projected number for 2018. In the bright red color represents the reported number of assaults. The light red represents the reported number of self-harm incidents. In 2017, both reported assaults and reported self-harm incidents increased from 2016. Reports of assaults increased by 157%, while the reports of self-harm increased by 7.14%. On this slide, we have 2 pie charts. The pie charts pictured compare the circumstances necessary for the use of emergency restraint and emergency seclusion in the school year of 2012-2013. The blue represents the risk of injury to others. The red represents the risk of injury to self and others, and the green represents the risk of injury to self. This last slide we have for the pro argument of the use of restraints and seclusion is a short clip of Dr. Jonathan Tarbox, a PhD, BCBAD, and he is the Director of Research and Development at the Center of Autism and Related Disorders, and he shares some important information regarding the use of timeout and restraint. It's not opening. So now we'll turn to Kristen for the counter argument.
Okay, I'm going to just talk about some research for the pro use of restraint and seclusion first. And what we found is that research has been conducted on both sides of the argument for the use of restraint and seclusion. Overall, the research we have found documents the need for physical restraint and seclusion in emergency situations. Students with excessive aggression or self-injurious behavior put themselves and others at risk. In these situations, properly trained individuals are able to carry out restraint procedures in order to minimize the risk of further injury to the student or to others. One of the research studies that we found was in a descriptive study of the use of restraint and seclusion in a special education school by Villani Parsons et al. In 2011. This study was completed over a 6-year time frame in a special education school setting. The students attended the school had needs that the public schools could not address. Data was collected over the 6-year span, including frequency and duration of aggression and self-injurious behaviors of students from elementary and high school age. The staff at the facility was trained in professional crisis management, also called PCM, which was used in addition to positive behavior supports and de-escalation strategies. Using PCM, staff was trained to only use restraint and seclusion for dangerous and aggressive behaviors. All other behaviors would be treated by implementing behavioral interventions. The study concluded that when staff is properly trained, the restraint can be used to manage aggression. The results of this study were similar to that of inpatient facilities that conducted similar research. Villani Parsons et al. Suggests that future studies should focus on those students with excessive aggressions that could cause outliers in the research that we typically see. Another article we looked at on the pro side of use of restraint and seclusion was the professional practice and ethical issues related to physical restraint and seclusion in schools by Sherman Peterson et al. In 2016. In this article, the authors looked at the ethical issues that arise from the use of restraint and seclusion, and they are quoted saying, "In some situations, when these behaviors are so extreme that they threaten the safety of students or others, educators may use either physical restraint or seclusion to help manage these aggressive or otherwise challenging behaviors and prevent injury." The article cites several organizations, including the Autism Society, that have stated that restraint and seclusion are necessary. Staff and caregivers should be trained on proper procedures for when a need may arise. Other agencies make claims that if restraint and seclusion are necessary, then the treatment has failed. In other words, prevention strategies should be used to teach students to manage and prevent future aggressive behaviors. Sherman et al. Concludes that environmental factors impact the implementation of behavioral programs, and therefore, even with the most effective program and staff training, restraint and seclusion will still present ethical issues. In an effort to reduce ethical issues, the authors advise educators and other professionals to undergo extensive training so they can make the best decisions for a client in a moment of when a crisis arises. So that's the research that we found for the restraint and seclusion. So now I'm going to go to Denise for the con side, and then I'll be back with more.
Hey guys, I'll be addressing the opposing views of restraints and seclusion as my counter argument. Restraints and seclusion have become widespread throughout residential group home settings and school systems to prevent the client from causing any harm to themselves or another individual in the environment, and is in place as a means of a safety precaution for the individual or others. In respects to the professional and ethical compliance code set in place by the BACB, one would question, are restraints and seclusion the best alternative for the client? Do restraints and seclusion cause more risk than benefit to the client in the long term? Are restraints and seclusion in fact causing further trauma and or regression for the client? How are restraints and seclusion beneficial to the client's well-being and progress in the long term? As stated by Mason, despite the fact from the seclusion remains mainstream in clinical practice internationally and is sanctioned in international law, its use remains controversial, being described as social control and felt as manipulative and punitive by patients. There's no doubt that seclusion is coercive except in the rare instance where it is requested by the patient, usually in the form of advance directive. Even in this case, it may be felt as coercive at the time of implementation. Death, trauma, psychological effects such as anxiety, fear, rage, nightmares, and mistrust are just a few to mention that may result from the restraints and seclusion from individuals and disabilities. I actually do have about 5 years experience implementing restraints and seclusion in a non-public school for children with autism, and I honestly only saw 50% of the restraints and seclusion implemented that was really necessary. I observed a lot of restraints that I questioned the ethics behind it. I questioned how the client felt after and their progression and the regression overall. Restraints are dangerous and it hurts students. Research shows that students have had serious injuries and even have resorted to death. Gust and Sancto, 2012, reports that students suffered from trauma due to restraints and seclusion. For example, in 2008, a 13-year-old boy named Jonathan King hung himself in a seclusion room with a cord his teacher gave him to hold his pants up. Then in 2012, Corey Foster, a 16-year-old boy, died during an 8-person prone restraint used to subdue him after he became aggressive towards staff. 70%, as reported by the Council of Parent Attorneys and Advocates, did not give consent for restraint procedures. Regulations for restraints are not clear enough, and ending cycles of restraint are unclear. Restraints and seclusion have also been overused and not implemented correctly by staff. Students with aggressive or self-injurious behavior often have restraint and or seclusion included in their IEP as a planned intervention. But there's no way to determine when the seclusion should be removed from the IEP. However, Ryan and Peterson, 2004, reports that there is no research to support the use of restraint as an intervention. The Supreme Court records show several cases where restraint and seclusion have been misused, and other intervention strategies have been researched and should be implemented first. Least restrictive environment is required. Seclusion should only be used in extreme cases and only be temporary. and not as a means to calm a student, as Brian had mentioned earlier. Research also suggests including other students be removed from the classroom while behavior support plan with communication training is used rather than removing the student with the problem behavior. Emphasis should be placed on prevention, positive behavior interventions, and supports. Restraint or seclusion should only be used within a comprehensive behavior support plan, and highly trained staff should be implemented restraints or seclusion. Data should be recorded and monitored regarding the restraints or seclusions and should never be used as a means of coercion, discipline, convenience, or calming a student. There are several ethical issues involving the use of restraint and seclusion. These concerns include but are not limited to the potential for death or injury, failure to use the least intrusive intervention and evidence-based practices, inappropriate restrictions on liberty and removal from access to education, repeated use of restraints or seclusions as a failure of programming, disproportional use with certain critical groups and insufficient training, supervision, and monitoring. As a behavioral analyst, one of our core principles is do no harm. We must constantly assess situations and ask ourselves, is the course of the action causing harm? Unfortunately, there have been several cases throughout the United States where the use of restraints and seclusion have led to death and injury. For example, in the use of restraints and seclusions, for example, in 2018, a 13-year-old boy named Jonathan King hung himself. Again, we talked about Corey Foster, the 16-year-old that had died during the 8-person prone. However, one cannot dispute that sometimes behavior needs to be stopped. As a behavior analyst, we should not allow our client to continuously bang their head into a wall, potentially causing long-term damage to their brain, nor should we allow a client to continuously hit others. We must also keep in mind that we must utilize alternative behavior supports instead of resorting to restraints and seclusion primarily. When the use of restraint or seclusion is an unavoidable situation, there are guidelines that should be followed to ensure the safety and dignity of the client. These guidelines include restraint or seclusion should only be used after least restrictive interventions have failed, positive behavior interventions and supports. Emphasis should be placed on prevention. Restraint or seclusion should only be used with a comprehensive behavior support plan, which should be included in the IEP if it is in the school setting. Only highly trained staff should be implementing these restraints and seclusions. Data should be recorded and monitored regarding the restraint or seclusion. Restraints or seclusion should never be used as a means of coercion, discipline, convenience, or retaliation by staff. We're going to go ahead and go back to Heather, and we're going to look at some visuals for the counter argument.
Before we move on to the counter argument, I just want to briefly pull up the talk from Dr. Jonathan regarding the use of the restraints.
On steroids, I guess, this whole idea of putting the kids someplace else. And so I kind of wanted to know from a research perspective, how is the idea of else? Friday, it's 11 o'clock. It's actually later than 11 o'clock, but it's time for research with Dr. Jonathan Tarp. And this whole idea of people not understanding and feeling like they need to restrain a child, if you could enlighten us in terms of your experience and research, that's a lot. That's, yes, go. What can you tell us?
All right, well, yeah, there's a lot to deal with, but first, actually, let's start by clarifying some terminology.
Okay.
Because it's always tricky to know exactly what we're talking about. And I'm
Right.
sure, as you're saying, different school districts and different parents and different teachers are using different terms. Let me say off the bat, I'm not an expert in scream rooms. I'm not sure exactly where that term came from. I guess the idea is let the kid kind of scream it out and kind of get out there, express their aggression or something like that in a way that doesn't hurt anyone.
Including
So let's just define some terms that are real terms. One is a seclusionary timeout, and that's where you place someone in a separate area. It's timeout from positive reinforcement. So you take them out of their normal environment, which should be full of positive reinforcement, and you seclude, and you seclude them in a separate area against their will, generally, and that can be done as a consequence for behavior, in which case it's a punishment procedure if it actually works, or it can be done as an emergency intervention. So that's another distinction that's kind of important to make too. A punishment procedure or an intervention therapeutic procedure versus an emergency procedure. So something that you're doing temporarily that is not intended to actually help the behavior or help the individual in any way, but is simply done as an emergency procedure to prevent injury is usually referred to as an emergency intervention or emergency procedure.
So as Dr. Jonathan stated, these interventions should only be used as an emergency, as a last resort. So now we're going to turn to the use on the counter on the use of restraints and seclusion. The BACB Ethical Compliance Code specifically codes 4.08 considerations regarding punishment procedures, and code 4.09, the least restrictive procedure, indicates that restraint and seclusion are not a primary intervention. But there are several suggested solutions to reduce the use of restraint and seclusion. The first solution is early identification and intensive early intervention. With an emphasis on prevention, the need for restraint and seclusion is minimized. Staff should not only receive training on how to safely implement crisis intervention procedures, such as the 3 holds that we saw earlier, but also on training on how to prevent and de-escalate crisis when they occur. Other solutions include simple intervention techniques, problem-solving strategies, reinforcement-based strategies, and extinction of inappropriate behaviors, inclusion and timeout, and exclusion timeouts. On this slide, we have 2 pie charts. The pie charts pictured compare emergency restraint and seclusion via an IEP by primary disability during the 2012-2013 school year. As you can see, the blue on both the pie chart represents the diagnosis of autism. Autism appears to be the primary disability where emergency restraint and seclusion is actually written on the child's IEP. Next, we have another short clip. This clip depicts how restraints and seclusion should be used as a means of ensuring safety and how detrimental the effects can be for the individual if it's used for long term.
They're treating children like they're not human.
Shocking video of autistic children being restrained, roughed up by their teachers.
Tonight's shocking video that has turned all eyes on Massachusetts. They call it discipline. Others call it child abuse. In fact, you may not believe it unless you actually see the video. Not only were the alleged victims children, they're mentally handicapped, autistic. And to top it all off, it all took place in the public schools. Good evening. Welcome to Pros and Cons. I'm Nancy Grace. When you drop your children off at school or maybe even the bus stop, most parents go about their day with the knowledge that their kids are safe at school. But when you see this video of autistic children crying out loud, afraid, faces bruising into the floor, knees of adults crushing into their backs as they lay helpless, it's incredible. Helen Lukatis has defenseless, and some say they make for the perfect victims because they can't communicate. Well, what happened inside one Massachusetts classroom for autistic children was captured on videotape, which we are about to show you. And this is also happening today in other schools all across the country. We warn you, it is difficult to watch. After one mother did, she decided to sue in this shocking story of violent lessons.
So now we're going to turn to Taylor for some conclusions.
Okay, so as you can see, the use of restraints and seclusion on individuals with disabilities is and will continue to be a controversial issue. Because of the risks of emotional, physical, and psychological harm to the individuals, many argue that the use of these procedures is more damaging than anything else. However, others argue the need for physical management if an individual is severely aggressive to themselves or others, or if previous interventions have been proven to be ineffective. All this considered, it is essential to protect the individual's rights and comply with ethical codes while also ensuring the safety of themselves and those around them. This will conclude our debate, and thank you all for watching.